Thank you for joining. Yeah, so the point of this webinar, and this is our first one doing it, is Ask the Orthopedist. And so at the end, if there's any questions you have about orthopedic surgery in general, any sort of ailments to the musculoskeletal system, feel free to ask. This is to be an open sort of format where you can ask anything related to your health in the musculoskeletal realm. I'm always, whenever we have this, going to present a specific topic and just sort of give a brief presentation so we all hopefully leave by learning something. And for this first one, I wanted to talk about joint replacement surgery because I primarily subspecialize in hip and knee replacement surgery, everything from the minimally invasive to the revision surgeries for the hip and knee. And so I'll go over just sort of a brief presentation and then we'll get to your guys' questions. So the goal of this presentation is just to do a brief review of the normal anatomy of the knee and the hip, because that's important as far as the conditions that will lead to pain and conditions that lead to arthritis in the knee and hip, and then ultimately what the goal is for the replacement surgery. So going on after the anatomy, sort of what is arthritis, what are the other conditions, how can we prevent these conditions from occurring, and then how can we treat them non-operatively? And then ultimately, when it's time to have a replacement surgery, when should you consider it and what are the ultimate outcomes? What can you return to do? So looking at the knee, so the knee joint is a hinge joint, essentially. However, it's more complex than that. Most of us think of the knee as a knee that just, a joint that just bends, but it also rotates, it moves side to side, it bends side to side, it shears, and there's compression and distraction. So lots of motion that actually happens in our knees rather than just simple bending. There's a lot of muscles and tendons and ligaments that are all surrounding the knee joint, each of which can get injured and cause some pain. And that's where working with your clinician to determine the source of pain comes in key to sort of find the correct diagnosis and to treat it appropriately. Not only are those muscles and tendons surrounding the knee, but the bony anatomy and the anatomy of the joint itself is fairly complex. We think of it as three articulating surfaces between the femur, the tibia, and then underneath the kneecap as well. And our body really does an amazing job as far as creating a well-functioning structure. And so the cartilage is the smooth surface that you can think of as sort of ice on ice. And an interesting fact that I think is really cool is that the coefficient of friction, so the actual friction between the surfaces of cartilage, is actually significantly less than if you were to take ice and rub it on ice. And so it's a pretty remarkable structure. The meniscus is a shock absorber that's in between the two bones, so the femur and the tibia, that absorbs the pressure as we walk on our knee and helps distribute those forces. Because our knee sees a lot of forces. And this table just sort of demonstrates how many newtons, which is a measurement of force on a certain object, that our knee encounters when you do certain activities. And I'll just bring your attention down to the deep squatting position. So just your body weight, if you go into the deep squatting position, areas of your knees see 15,000 newtons, or that's 20 times your body weight. And so the pounds of force in a particular areas can be up to 4,000 pounds just from a normal body weight individual going to the deep squat position. So a lot of force. And so it's no wonder why knee injuries are so common, and there's multiple ways to get injuries. Then we move to the hip joint. The hip joint is considered a ball and socket type joint. And so from the mechanics of things, it's fairly more simple. And this is what it looks like here. Everything that moves around a ball and socket, so it has a center of rotation. So we have all these motions, so flexion, extension, abduction, so bring your leg out, adduction, bring your leg in, and of course, rotation around that singular point becomes key. Arthritis in these two joints are very common, something that almost all of us will get if we don't already have it. Just looking at knee arthritis, there are about 19 million individuals suffering from it. And there's been multiple studies that looking at this and surveys, and roughly 1 out of 5 Americans over the age of 40 already have arthritis in their knees to some extent. And why does that happen? And that is because that as we age over time, that cartilage, something that previously was like that ice on ice, just starts to change in its biologic structure over time. So it starts to swell with water, the proteins degrade a little bit as we use it more and more and as we age. And then ultimately we get inflammation in both of these joints that ultimately lead to this. And this is what arthritis looks like in the knee and the hip. So in the knee, this is what a normal knee x-ray looks like. If you were to stand on it, again, you can see a nice cushion right here. So this space in between tells me you have good cartilage left, as opposed to right here where you don't have that space anymore. You start to get bone on bone rubbing. The same goes for the hip, or this on this hip. This is technically the left hip, even though it's on the right side. That cushion is a good cushion. Whereas you go on the other side, again, you don't have that anymore. So you start to get bone on bone. MRIs, I commonly get this question in the office, well, I got an MRI, why do I need an x-ray? It's because an MRI, you're not standing up, so I can't see functionally what your hip is doing. And MRIs are very useful to look at those ligaments and tendons around. If you don't have much arthritis and you still have significant pain, then we look at the ligaments and tendons around to see if anything is injured that is causing your pain there. Ultimately, what arthritis and these degenerative changes will lead to, and the symptoms that you'll start to notice, is that it's really a gradual onset. So it tends to sneak up on a lot of people. And I think all of us get aches and pains every once in a while, but this is a type of ache and pain that typically comes and then doesn't go away without some sort of intervention. It's typically worse with activity, and in the hip, most patients complain of groin pain and sometimes a deep buttock pain and pain that goes down to the thigh and even the knee. Additionally, if you may notice, if you're very keen, your leg may actually begin to shorten as you lose that sort of cushion as well. The knee, you typically tend to feel the sensation of crunching or catching symptoms. And then eventually, as the ligaments around the knee start to loosen over time, because you lose some height with wearing of the cartilage, your knee may start to feel unstable. And you may notice that on this image on the right, your knee starts to bow in or bow out. Some people in. And there's many other conditions that lead to it, so not just arthritis. And these are just some examples here. So previous infections, some people are just born with less cartilage and more prone to be getting these degenerative changes. Inflammation, so certain inflammatory conditions such as rheumatoid arthritis, psoriatic arthritis, all of it leads to the same mechanism of wearing away the cushion of the knee until you get bone-on-bone arthritis. So they all lead to the same endpoint. And so the treatments for a lot of them, since you're dealing with the same endpoint, are fairly similar. And so the top treatment modalities, obviously, are going to be activity modification. So if pain with certain activities is what's bothering you, trying to see if you can live the life and the exercise regimen you want to have with adjusting the types of activities that you do in order to stay healthy. Again, our goal is to keep you healthy and keep you doing the activities you love. And so that's where coordination with your surgeon and your physician is key. Physical therapy to help strengthen up those muscles. And so even if you get bone-on-bone arthritis, so you don't get instability, making sure you have strong muscles is important. Medications such as anti-inflammatories. If you can lose some weight, losing weight always helps, less pressure on the joint. And then ultimately, if you need a cane, so you prevent falls, is another option as well. And then injections, which we'll go over here in just a moment. And there's a lot of other treatment modalities that you can do as well. And if anyone has any questions about any particular one, happy to chat about it. But if you just look up this guideline, we actually meet about this pretty frequently within the joint replacement world. And I go to this conference every year, and we last had a consensus meeting where we reviewed all the literature that there is out there in the world and made our recommendations. Back in 2021 was the last time this happened. And based off the evidence that are out there, we categorize it into the treatment modalities that seem to work the best and those that either don't have enough evidence or don't seem to work. And so these are the treatment modalities that work the best as far as you should try if they work for most people. And that those are, so obviously exercise, we talked about strengthening the leg, patient education, which is really for us. And my job and one of my roles here today is to make sure everyone here is educated as far as these conditions. Anti-inflammatory medications can help with the pain, whether dietary or actual medications. Acetaminophen is Tylenol, and there are various other topical treatments that seem to help as well. These are the ones with 3 out of 4 stars, so those that help, but not necessarily will help for everybody, but the ones you should definitely try. So those are the steroid injections, canes, some braces for particular types of individuals and deformities, more training, and then partial meniscectomy or the arthroscopy for certain individuals who have a meniscus tear and have mechanical symptoms such as catching or locking. It may help improve some of their symptoms for some time. Everything else falls into this limited evidence, or not if sufficient evidence to make strong recommendations. And so this is where there's a lot of options that are good for specific patients, but it's really tailored to individual conditions. And some of these are oral supplements, dietary supplements, other therapies, laser treatments, acupunctures, PRP or plasma injections, the hyaluronic acid or the gel injections, okay? And then, of course, narcotics we try to avoid in general. It does work for certain individuals, but it's a case-by-case situation. So something you should talk about with your surgeon. And then ultimately, when all those options fail, that's when you should really start to consider a replacement type surgery, right? And so if your lifestyle, if you're not living the lifestyle you want to be living because of hip or knee pain and those options aren't working, that's when you should consider this. So starting with the knee replacement, it goes back to the anatomy we sort of discussed. So the goal is to restore pain-free function, give you back stability, and then motion of the joint so that you can go back to the activities you want to do. We're a very active community here in Southern California, so a lot of my patients want to get back golfing, get back longboarding, playing pickleball, things like that, which you can do. It's just, you have to have the correct diagnosis. I recommend trying everything before then. And despite the name as far as a total knee replacement, which I think can scare some people, it's really kind of a resurfacing procedure. And as you can see in this picture here, I carefully measured 9 millimeters of bone to remove.
Essentially what I was saying, so the knee replacement's a good option, and there's been a lot of advancements over the past couple of years, or a couple of decades, especially within the types of materials that are in there. So we have some patients, and it's not many, that have metal allergies or reactions to specific metals. And so there's been a lot of advancements made as far as some metal or common metals that people are allergic to, sort of getting rid of those and providing other alternatives. I think you can't talk about knee replacement surgery without the consideration of the less invasive partial knee replacement surgery. Another thing that's been researched a lot in the past decade or two. And our indications for these are really advancing and being more appropriate as more young patients get arthritis. And especially in our community, we have more active patients in the area. And I'll go over the pros and cons as far as when you consider this. But a partial knee replacement, as you can see here, just replaces part of the knee. And so if you only have arthritis or that bone-on-bone wear on one side of the knee, then the partial knee replacement becomes an option. What are the pros and cons of a partial knee replacement? So in general, they tend to be a little bit faster in the recovery, a little less invasive. So it's a smaller implant, so I can do it through a smaller incision. Easier revision. So if in the future it does fail, I can just convert it to a normal total knee replacement surgery. And then they tend to have a little bit more higher activity afterwards. The con is that you can still get arthritis in the rest of the knee, and they almost last as long as the totals on average, but generally, since it's a smaller surface, doesn't last quite as long. And there's some unique things that you have to consider, and you should talk about your surgeon with if you're considering it, that come with it, such as if you have really poor bone, the potential for a stress fracture, or if you have a big deformity. So as we talked about earlier, bowing of the leg, either out or in, you can't really correct that with a partial knee replacement. Whereas the total knee replacement, which is very appropriate for majority of patients, it replaces the entire joint, so you can't get arthritis anymore, and you can correct these deformities that occur. Longevity, so it tends on average to last a little bit longer than the partials, but it's a longer recovery. And if you are going to need a revision in the future, so say you're a younger patient, so younger than 60, for example, you likely will need a revision in the future. And that revision, although definitely possible to get your mobile knee, will just be a little more difficult to recover from. And again, this is just one example, one of many studies that we've done looking at this. And then on average, again, the partial knee replacement recovers faster and may have better function than the total knee replacement. However, they tend to last almost as long, just not as long as the total knee replacement. Going to a total hip, again, think about the anatomy, restoring that ball and socket joint. So there's certain things we think about. So of course, in the hip is recreating that smooth surface, but then we can also adjust leg length. So if your leg's shortened from the hip, we can get it back out to length. Okay, and this is what it is sort of made of. So you have a metal cup portion that the bone will grow into over time. Inside that, there's a plastic liner. and then a femoral head, typically made out of ceramic these days, and then a femoral component that goes inside the femur that's made out of metal that, again, your bone will grow into most of the time. Some of these are cemented. There's a lot of different approaches, which many of you may have heard of. Essentially, just there's a lot of ways to get inside the hip. The most common ones that you hear about are the anterior and posterior. So the anterior is going from the front, posterior is going from the back or the side. What I choose to use in the majority of my patients are that less invasive anterior approach, because I can go between the muscles. And a large portion of it is because I can use technology. So I can use x-rays in the case to confirm and make sure that your implants are going in the appropriate position to improve the accuracy. What the anterior approach has shown is that in the early period, within the first 3 months, you may have a little less pain. It's a little bit more stable of a surgery afterwards. However, regardless of what your surgeon chooses to do, anterior, posterior, from the side, as long as it's done well, you do well. And the hip replacement surgeries really are an amazing surgery as far as returning function. Other advancements that have been made over the past decade, and if you have had a joint replacement in the past or know somebody that has, it's really almost an outpatient surgery for most patients now. I'd say about 50% of my patients go home the same day, and that's because we've really dialed in this enhanced recovery protocol. And that is coordination with our anesthesiologists, with you as our patients, with our nurses, to give you the medications that avoid things like dizziness and nausea and stuff like that around the surgery pretty significantly. And we get you up walking within 2 hours after the surgery. So we get you up moving, putting weight on that new joint almost right away. And so there's a lot of advancements that are made with these protocols to help decrease the pain and get you moving. Other advancements that have been made that we have at Mission Hospital. So of course, the implants have changed quite a bit. I mentioned some with the metal earlier, but there's also now different technologies that allow your bone to grow into these implants to hopefully make the implants last longer over time, which is what it's showing in the literature and the data. And then there's a whole other conversation we could have if anyone has any questions about custom implants. And although customs are appropriate for some patients, there's so many options that we have with the manufacturers. This is just an example of some, and again, it's too much detail that I'm not going to talk to you about today. But if anyone has any specific questions, we have a lot of these options in the implant system that I choose to use. I can personalize it to your specific disease and your anatomy. Additionally, the plastic has been significantly redesigned, and the plastic used to be the way 20 years ago how these things would fail, and however, it's not even a concern anymore for the majority of patients and clinicians. There's a bunch of other enabling technologies that we use in the operation as well. So I use navigation or robotics for every joint replacement surgery that I do. And here are just some examples of it. At Mission Hospital, we have the ROSA robot, which I'll show you on the next slide, that lets us really dial in what we want to achieve during the surgery. I also do some work on the augmented reality headset and future applications for that, which if anyone has any questions about it, it's a pretty cool enabling technology. This down here is an example of a custom implant for complex cases. And then now coming out, just released this year, there's the potential for smart implants that, again, another conversation in itself, but these smart implants can help monitor you over time after the surgery for the next 20 to 30 years, giving us information to help better care for you. This is the robot that we have at Mission Hospital, and this is the information that I receive real time in the operating room. And so a lot of numbers on the screen, but I'm just putting this up here to show you. With this, I can make the surgery as precise to the millimeter and to the degree to execute the plan that I have made for you to a precise and accurate, in a precise and accurate manner. And then ultimately, what do you care about? So what can you do after the surgery, and what do we want to get you back doing? And so on average, after joint replacement, you'll experience significant functional improvement about 4 to 6 weeks after the surgery. And 4 to 6 weeks, no matter how less invasive or maximally invasive the surgery is the number, because the bone gets bruised and the soft tissue needs to heal. Our biology is a limitation to some extent on that. Some patients will do better, and it'll be maybe 2 weeks. Some patients may take a little bit more time. It's really individualized, but on average, 4 to 6 weeks. And the full recovery takes about 3 to 6 months. And then sometimes it can even take up to a year in the literature that shows, depending on how much strengthening you need and how long you waited until having that joint replacement. Okay. This is a consensus from one of our national meetings that all the surgeons received. And on average, everyone typically agrees on the type of activities you can do. And most of our patients are going back, these first two columns, going back to all of these activities you can see here. Again, you should keep in mind that after you have a joint replacement, it's kind of like new tires on a car. The more you use it, the more it's going to wear. So although you can go back to all of these activities once you're fully recovered, you may want to avoid high impact type of activities or activities where you may fall frequently to avoid any complication. But most activities that you do on a day-to-day and any exercise activities you like to do tend to be okay. This is just one case example of a complex case. I think I chose this one because I know you aren't physicians, but I think you can appreciate the differences between these hips. So this image on the left is the normal hip. This one is a severe congenital or a hip that when the patient was a child is significantly degenerated. And with these technologies, it really makes it a simple surgery and can accurately execute this plan to do this reconstruction here on the left. Now the patient was going from not walking in a wheelchair to walking and even performing athletic activities.